The views and opinions expressed in the following program are those of the participants and do not necessarily reflect those of KSMQ Public Service Media Incorporated or its assigns.
Special presentation of Health Connections. Tonight we're discussing H1N1 novel influenza, and we have several experts in the studio to answer your questions. Stay tuned. You're watching Health Connections. Tonight. I'm your host, Stephanie Passingham. Our studio guests tonight are Bridget Campbell from Mower County Red Cross, Patty Abbott, infection preventionist, Patty, with Albert Lee Medical Center, Larry Edmondson, Director of Disease Prevention and Control for Olmsted County Public Health Services, and from the Minnesota Department of Health, Eric Anderson. Thank you all for being here tonight. We'd also like to welcome the audience joining us here in the studio. All of you at home can also join the conversation and ask a question by calling 1-877-4MY-KSMQ. That's 1-877-469-5767. Or you can go to twitter.com/KSMQ and post your question there. We're going to start tonight with a short clip bringing us up to speed on the last several months. Let's take a look.
In March 2009, the first cases of the H1N1 novel influenza appeared in Mexico. Within 1 month, the Centers for Disease Control confirmed several cases in the United States, and by late April 2009, H1N1 is declared a public health emergency. Health and Human Services Secretary Kathleen Sebelius announces preparations for a new flu vaccine in early May. After 2 months of buildup, the World Health Organization declares a global flu pandemic for the first time in 41 years. As most of the news focuses on Congress over the summer, flu preparations continued for students returning to schools and universities in late summer. More cases and deaths are reported through the late summer and into the early fall. By October, vaccines for H1N1 are available to select high-risk groups and later available to other groups.
By just kind of getting a basic understanding of what this H1N1 influenza is. And Eric, we're going to start with you. Can you tell us what this is and how it differs from the regular seasonal flu influenza that we're more familiar with?
Okay, well, the H1N1 is what we call a novel influenza, and that it's a totally new type of influenza. And what's happened is it's an H1N1 type of virus has gone through what we call a genetic shift. The typical seasonal influenza will change slightly from year to year. We call that a genetic drift. But with a H1N1, it's gone through a total shift so that it's different from any viruses similar to it in the past. What happens when you get a novel virus like that goes through the genetic shift is that it becomes much more easily transmittable among people. And people generally have no immunity to it because they haven't never been exposed to it before. So it's a new virus.
Okay. Now, Patty, when you start seeing this, are the symptoms, the behaviors of this virus any different than seasonal flu? Better, worse, different symptoms that people should be looking for?
The symptoms are pretty much the same as the seasonal flu. With regard to the body aches and the fever, those kinds of things are very typical, just like the seasonal flu.
Okay.
The main difference is that we see it in this particular case occurring more among younger people, where the seasonal flu has been typically more common among older adults.
Okay. Any guesses as to why that is?
We think probably because what Eric was saying, that we have a less immunity. Some of us that have a few more years underneath our belt, we've seen a few flu seasons, have probably developed a little bit of immunity that may protect us from this particular virus.
All right. Now, Larry, when folks are feeling under the weather, at what point should they decide to seek professional health care or just say, I've got the flu, I'm going to stay home and stay put?
Well, fortunately, the majority of the people that are getting the H1N1 are able to tough it out at home and take plenty of fluids, get rest, and get over it on their own. However, some do get sick enough where their fever goes up, or maybe they start to dehydrate, or they start having additional symptoms, and at that time they should consult with their physicians to determine whether or not it's appropriate for them to come in. Also, if they have any underlying risk factors, if they have diabetes or asthma or any of the factors that have been talked about a lot in the media, they should be more concerned about consulting at least with their physicians, because they may be persons who would benefit from antiviral drugs.
Okay. And when you say when their fever goes up, what's up and what's the threshold?
Well, the threshold is over 100 degrees, essentially, that we say, for example, to stay home. Until it gets below that, you want to stay home for at least a day. It varies, and perhaps you'd want to speak to that more, especially in children. There's more criticality there than in others and so forth. So you might want to elaborate on that, Patty.
Yeah, children will typically have a higher fever, although we've seen a pretty high fever in some of our middle-aged victims of this disease too. 103 is not at all uncommon. Although I think statistically we talk about at least 20% of the people that acquire this virus don't have a fever.
Is that right?
Yeah.
Okay. So let's talk about some of the other symptoms then. How do they know they might have it, and when should they be concerned? You talked about not becoming dehydrated. What are some indicators that tell you that you're getting dehydrated? Is it simply being thirsty, or how do they know?
Dry mouth, not being able to, not urinating very much, a lack of body fluids. Most people will have kind of a dry, hacky cough, but the dry mouth is probably one of the first indicators of dehydration.
And since this is a respiratory issue, is cough always associated with this? Is it always dry? Should someone be concerned if they're congested? Give us a sense of what else they should be looking for.
Well, cough is definitely one of the symptoms in most people. And as Patty mentioned, something that's more typical of influenza generally, too, is body aches. Not everybody gets them, but many do, and those that do remember them, because sometimes that's the most outstanding symptom that you will feel.
And fatigue, sore throat, some other things like that.
Okay.
Chills. Those are a lot of the symptoms of it.
So it could be a combination of all of those.
Yep.
All right. Now, in some cases, I've heard on the news they say, if you think you've got it, stay home. Don't come to the clinic and infect all these other people. Again, let's talk about when folks should, what that critical stage is that they need to actually go in to see their provider. And then I want to talk about how they find out if they actually have it. So what's the critical tipping point of when they need to come see you as a nurse or come in and see the physician?
We typically are telling people that we'd like to have them call and get some advice, as to whether or not they should come in or not. But people that have other health underlying conditions probably do need to be seen if they're really down and out with the flu. And then people that have severe respiratory symptoms, if they're very short of breath, if they're having trouble keeping their color, people that are having cyanosis or blue lips, blue color should probably be seen.
Okay. There's been some conversation about people who tough it out and they seem to be getting better, and then they almost get a second wave of that. Is that a key indicator of H1N1, or is that a typical behavior of flu in general?
To be honest with you, I don't know.
I think what we are seeing a lot with this particular virus is that people do recover from the virus probably, but their immune system has been deflated a little bit because of the virus, and a lot of people are getting a secondary pneumonia on top of that. Okay. And that's a very critical thing, because that pneumonia can be life-threatening.
Right.
And that's again very typical of influenza in general. Seasonal influenza acts the same way.
And in some of the past pandemics, the secondary infections have been would have hurt a lot of people.
Yeah.
Okay.
And the pneumonias that are really one of the typical indications, or the typical things that we're observing among the ones that have died from this flu. The pneumonia is common.
Okay. So if someone kind of ends up with some of those symptoms that really start to look a little bit serious and they go in to see their physician, their healthcare provider, what can be done for them?
Well, they can be rehydrated if they're dehydrated. They can, and then give supportive care and make sure that if they have a secondary bacterial infection, that they be given antibiotics for that. Would you agree with that?
Yeah, and yes, that's very true. And an antiviral agent
Right.
for the right candidates. It isn't for everybody. A lot of times they reserve that for people that meet certain criteria, people that have the underlying symptoms.
And is that what are we talking about? Like things like Tamiflu? What?
Tamiflu and Relenza are the two antivirals that are currently recommended for this particular virus.
And it's really important that they get it as soon as possible after they start the disease.
Oh, okay.
It works best within 48 hours
Right.
of symptoms onset, and it's also most recommended for those individuals who have risk factors.
Okay, and is that what you were talking about, meeting specific criteria? What
Yeah.
would those criteria be
Yeah.
that they need to meet in order to be prescribed Tamiflu?
It's commonly prescribed or recommended to be prescribed for very small children, or for older, people that are over 65, people that have underlying health conditions, and more severe illness, people that are having difficulty breathing, would be recommended. Yeah.
Okay.
In general, people that are at greatest risk of having complications should they acquire the flu.
All right. Let's talk a little bit about, so folks are contracting this. Give us some general numbers, Eric. Your organization kind of keeps track of kind of the big picture. What does it look like out there now?
And our surveillance is based on hospital admissions with influenza-like illness and outbreaks in schools. So we keep track of all the hospitalized cases that have occurred in the state. And as of today, I think there were 1,240 hospitalized cases, including 12 deaths. In southeastern Minnesota, it's about 900 cases, so that gives you an idea of what's happening regionally. As far as school outbreaks, we ask schools to report to us if they have 5% or more of the enrollee or attendees missing, or if they have 3 or more children in a classroom in a elementary school who are out with influenza-like illness. And as of today, I think there were like 1,200 some schools that have reported to us since the school started in September.
Okay. Do those numbers concern you?
Well, actually the numbers, they do concern us. Obviously, we don't like to see that many people hospitalized. Fortunately, though, in the last week, the numbers of hospitalized cases and the numbers of school reporting to us have gone down. Hopefully, that trend will continue, but it could go right back up again. We just don't know.
Okay, so it sounds like there's some unpredictability with this particular strain. In terms of the regular seasonal flu, there are people who get ill and who there are deaths experienced. How does this compare to seasonal flu? We know there's reduced immunity because it's new, but give us a sense of those numbers compared to what you see in terms of the numbers of seasonal flu.
I'm not sure that we've been keeping track of the hospitalized cases of seasonal flu. We do school surveillance, and then we have some what we call sentinel surveillance sites that gives us an idea of how many cases are occurring in those sites. But typically, seasonal flu peaks more like in February. This one is since it's a novel influenza. The season for this influenza started in May, and it's continued on into October, which is very unusual. We would rarely see cases of seasonal flu, like, for example, in the summertime. We saw a lot of cases of this in the summertime. So.
And I think actually, too, we've seen 2 waves of this pandemic so far. It started in May, peaked about July, came down. It was down to nothing for about a week or 2, and then it started surfacing again about mid-September. So we're in, I'd say, probably close to the peak of the second wave right now.
We hope so, at least.
Well,
Yeah.
We hope so. If you look at historically the way the pandemic curves go, that's
they do occur in a couple of ways. Yeah.
Okay. And for those folks that have had the seasonal flu before, should they get H1N1, is that experience worse than the symptoms experienced by seasonal, or it just happens to be a different strain, but you're going to feel equally ill with either variety?
Well, it appears that their illness is similar to seasonal flu. Would you say that?
Yes, I think that's very typical.
Yeah.
And it varies a lot from individual to individual.
Right.
There are some people that seem to have acquired this particular virus and are well in a couple of days and up and about, and there are some that are ill for 7, 8, 9 days and very ill.
One of the reasons we do the hospital surveillance is we want to see if there's a pattern of more and more people getting a serious illness, enough that it would cause them to go to the hospital. If we start seeing things change and that people go from a seasonal type illness to a much more severe illness, that will trigger some reactions.
All right. I want to remind our viewers at home that if you are watching and you have a question, please feel free to give us a call. That number is 1-877-4MY-KSMQ or 1-877-469-5767, or you can Twitter us at twitter.com/KSMQ if you have a specific question for any of our guests today, or have had an experience with flu already and are kind of wondering, is this what you've been through and how can you tell, and further. Question, so if someone has had flu, how long are they contagious, and is it different with seasonal than H1N1, or is it the same? How long can they infect other people, and how does that happen?
No, you're probably infectious at least a day prior to your symptoms, and most infectious the next 4 or 5 days, and then it starts dropping off. It can remain. You can remain infectious for quite a number of days, and if you're a child, it seems to be a little longer often than it is in adults. But generally speaking, your level of infectivity is going down after about the 5th, 6th day.
And we tell most people that they can go back to work or school within 24 hours after their fever has after their temperature has returned to normal, without having taken some kind of a temperature reducing drug like ibuprofen or something like that.
Okay.
We do, however, suggest that healthcare workers are away from work, or excluded from work.
7 days.
People that work with patients should stay out for 7 days, and that's still the recommendation for daycare too, preschool children.
Yep.
So not only the caregivers, but the preschool children themselves.
That's right.
Need to be out 7 days.
Right. And one of the reasons with a preschool being heavier like that is that we've seen that the rate of hospitalization for preschool kids has been higher than children that are a little older. So that we're taking extra precautions, as well as knowing that preschool kids aren't quite as fastidious about how they wash their hands and take care of themselves. So it's harder to control in a child care environment.
Yeah.
And Larry, talk about how this virus is transmitted.
Primarily by coughing. It's a respiratory virus, comes out of the lungs, and if you're within 3 feet, 6 feet of somebody who's coughing, you can inhale it and catch the disease that way. It's believed to be primarily a droplet virus, so that it goes out and drops. It doesn't float around in the air for long periods of time. So that's the primary way. Also, if you cough on something that, or you cover your mouth like this when you cough, and you grab something, whatever you touch or wherever that lands is contaminated. Unfortunately, the virus is not one that sticks around for very long periods of time, usually less than 12 hours, 24 hours. However, for a period of time, if you were to touch that and then rub your eye or stick your fingers in your nose or your mouth or something, then you've infected yourself. So that's why we stress hand washing so much.
And you mentioned preschoolers perhaps are a little less fastidious about
That's
their
right. So
cleanliness habits and washing hands. Is that why we've seen this impact so many children, as opposed to typically it seems like when flu comes around we worry more about our elderly population?
I think it is more the immunity, the lack of immunity that the children have. The one difference that the difference in ages between this and the seasonal flu makes, though, is the deaths. We see a lot more deaths with the seasonal flu. We have statistically they say 36,000 deaths on average every year from the seasonal flu, and primarily because people that are older tend to have chronic illnesses that make them more vulnerable.
And you guys talked about secondary infections like pneumonia.
Correct.
Yep. One of the groups that also has been a special emphasis when I've heard them talking about distribution of the vaccine are pregnant women. Why is that the case?
I think they get disproportionately severe illness, and it can be very dangerous for them if they get infected.
Okay. And does that immunity pass along?
I'm not sure.
Actually, you can transmit some of it. We even recommend now that a woman who has had a child that you breastfeed, because breastfeeding helps to pass immunity along to the children, and we can give them some immunity to the flu virus, as well as to other kinds of illnesses.
Very good. We have an audience. Oh, excuse me. We have an audience question. Would you state your question, please?
Thanks for taking my question. I've been hearing on the news that the vaccine is an untested vaccine. They're kind of rushing it out there to get it out to the public. And now that we're on the subject of pregnant women, I'm wondering what kind of assurances we can give pregnant women that this vaccine isn't going to be adverse to their pregnancy, to their unborn child.
Okay. Thank you. Who would like to field that one? Go ahead, Larry.
I want to do that. And thank you for the question. I think that's a concern that's been voiced many times. And actually, this vaccine has been manufactured in the same way that our seasonal vaccine has been manufactured for many years. There's been no real change in the processes in either the injectable or the inhaled form of the vaccine. The only difference is the bug. We have a different virus, and it showed up at a different time of the year than what we're used to seeing these viruses. Normally, there's a surveillance done throughout the world continuously for influenza, and we pick up the strain we're going to use in the following year's vaccine in the spring of the year in the southern hemisphere. Well, since this showed up in May, that was too late to get it into the vaccine. Otherwise, you probably would have seen it as one of the 3 strains in the seasonal vaccine. So there really isn't a reason why one should be more concerned about this vaccine than any others. Now, when you talk about it was rapidly put through and everything, they were on a fast track. There's no doubt about that, but they didn't skip any of the process. In fact, I think that's one of the reasons that it's taking longer to produce, because they're waiting to do everything correctly, and unfortunately not enough of it grew per egg, so it's taking longer to make the batches than they had hoped.
You mentioned a good point, Larry. Thank you for answering that question for us. The vaccine is produced using eggs, and I know there have been some concerns of folks who have children in particular, it seems to come up, who are allergic or have allergies to egg products. And is that an issue, and what are the options for those that may have some complications? Are there other vaccine choices for them?
All of them are made in eggs. So any child with a severe egg allergy should go talk to his physician about what to do.
I think, too, they should also be careful that what they have is a true egg allergy.
Right.
Because sometimes people, they've maybe gotten a stomach ache, or they've had some other reason that, and from then on, maybe somebody's told them that they were allergic to eggs, but they've really never had it checked out. And this is important enough, I think, that it would be a good thing to have checked out with your physician to be sure that you truly are allergic.
All right, very good. Well, businesses, schools, churches, and communities are developing plans for dealing with H1N1. Let's take a quick look at what some people think about preparing for H1N1.
Do you feel like masks or other covering devices are effective in limiting the spread of this type of virus?
If it was here, yeah.
And you
the
would probably wear one if it was here?
Yes.
Thank you very much.
Thank you.
And do you feel if we should have reported cases in our area, do you feel that masks would be an effective way to limit the spread of this sort of thing?
I believe that hand washing is number one. And don't touch your face. Keep hand washing is very vital. And as far as mask, it is a tool. It's a great tool. But like I said, number one is hand washing. And staying home if you think you have the flu. Do not spread it. So I think that's the number one.
Say that next week or next month we have 10 reported cases in Rochester. Do you think that means that we should go out and buy masks and be very protective that way? Or how would you react?
Yeah, if in 1 week, if we went from 0 cases to 10 cases, then yes, I would wear a mask, even though I've been sneezing today because of allergies. Yeah, then I'd get a mask.
What if it was in 6 months' time? You know, in 6 months' time we had 10. If we just had 10 reported cases, regardless of the.
In 6 months' time? Mm-hmm. Well, that's what I think the real problem is. I think this swine flu is going to die out, and if it surfaces, it's probably going to die out for 6 to 12, 18 months, and then come back and be a major problem.
And then you might be concerned.
That's what happened in the last swine flu epidemic, or the real bad flu epidemic of 1918. Actually, it started in 1915 and 1916. If you look at the charts, they had a few thousand people who got it, and then it was dead for a year or two, and then it just took off in 1918.
Took everyone by surprise.
It just swept real fast.
All right, Bridget, now your organization, you're with the Red Cross, deals with a lot of community preparation for a number of things, disaster preparation and so on. How has H1N1 impacted the preparations that your organization does for our area?
Well, largely our organization has concentrated on educating the public on ways of helping them prevent the spread of any flu, not just H1N1, but flu prevention. That's been a goal of ours throughout the summer and into the fall. And also we've had to, the Red Cross as a national organization has figured out ways in which we can still operate disaster response, and our blood collection is huge. We're the largest supplier of blood in the country, and so how do we make sure that there's a safe and adequate supply of blood still available? And so those are some of the ways it has affected the Red Cross.
And how is blood collection impacted? Because that's something a lot of people participate in. Can you collect from people who maybe have this active virus, or are they restricted?
Well, everybody that goes in to give blood is pre-screened. And so if they've had flu-like symptoms within the past 24 hours, they're advised not to give blood and to come back when the fever has gone down, and it's been another 24 hours since they've been symptom-free without any fever-reducing medication.
Okay. And have you noticed an impact in the amount that you collect in your various blood drives since this H1N1 came on the scene?
The blood supply has gone down. We are collecting fewer pints of blood, and whether that's because more and more people are sick, or we're not sure why it is at this point, but there does seem to be a trend that the blood supply has gone down, or our collection of the blood supply.
Okay. Now, Larry, I'm assuming part of your organization, since your disease prevention, is preparing the community and providing education information on how to not get it in the first place. But talk a little bit about how maybe some of our larger communities like Rochester are dealing with this, and what preparations are in place to try to minimize the impact of H1N1.
Well, we've been actually preparing for a pandemic for about 10 years. So we've done a lot over the years in preparation in terms of education, public education, pulling together groups of, in Olmsted County, for example, we've had a group that's been meeting monthly for disaster preparation for about 10 years now. And it's trying to primarily to find out what are the strengths of all the different organizations in town, what can they bring to the table when something happens, and then also working together cooperatively. So with this particular event, we've met weekly with, we being public health has met with the two primary medical providers there. We meet with the Red Cross, we meet with police, fire, the emergency services individuals. There's a wide assortment of people that are involved, and primarily get the word out, and each of us have our own little roles that we play. If we put on a clinic, for example, or if getting the information out, we try to coordinate the information we put out in the public so that one isn't saying one thing and somebody's saying something different, so that that we get our act together, so to speak.
Okay. And what is your primary goal with this team? Is it to prevent infections or to control it when you know they're going to occur? What's your objective?
Well, there are multiple. One is surveillance. It's waiting for and looking for something like this to happen and detecting it early so that you can intervene early. It's having exercises for different kinds of events and practicing them. We do a lot of things to get prepared for it, and then we've found that we're actually doing some of them now.
All right, very good. We have another audience question. Would you state your question, please?
I would like to know, do you find that in your planning for pandemic, is the severity of H1N1 at the level that you anticipated that it would be at, or is it more severe or less severe than what you thought? And maybe as a second question to that, if it's less severe, are we getting a little too lax in the feeling that, well, we're all going to be fine, we can just go back to our ways? So that's what I would like to know.
Well, I know when we've been doing our planning, we plan for the worst and hope for the best. Mm-hmm. In other words, we plan thinking that it might be a really severe disease that causes a lot of death, and we plan how to deal with it. And we hope that it continues to be just like the seasonal influenza, that the disease continues to be relatively mild. Would you
think that it is fairly mild at this point, milder than what we had anticipated?
The disease itself is fairly mild, but we're getting a lot of people who are getting it, and that's unfortunate. We don't like to see people get sick. But so far, it seems to have stayed similar to seasonal influenza.
I think that's one of the main purposes of our emergency planning is that what we call an influx of patients, that we see a large number that gets beyond our ability, right, our normal ability to handle, so that we have plans in place for dealing with that. And a lot of it is cooperative. A lot of it is relying on each other, not just hospitals, but the public health, the fire and police departments and hospitals together.
And I don't think that we've become very complacent, because this has been a very difficult thing to deal with the number of cases we've seen. My department is partially responsible for distributing the vaccines and some of the antivirals, and that's been very time consuming. So we take it really seriously.
There are experts that say that it's not if, but when that next really major health crisis happens. And what we're doing right now, even though it might be more than was needed for this particular event, we're preparing for that larger one too. Right. So it's good practice for us.
And actually, there have been a significant number of people hospitalized in Minnesota with this disease, and many visits to emergency departments. And like Patty was alluding to, one of the concerns we have and have had is that even without lots of deaths, if you have a surge into your emergency departments and into your hospitals, it doesn't take much to tip them so that they can't take any more people. And then you have to have plans for alternative methods of caring for people, either in their homes or in other sites. And that's one of the things we've all planned for. We all have contingencies for that if that were to occur. Right. And this is part of what we've been planning in Olmsted County with the two medical centers there as to what constitutes a tipping point and what's our next move or moves.
Mm-hmm. And not to hog the microphone, but one last question. I know that I've heard that, literally thousands of people have been calling the flu hotline with questions. Could you just tell us, what sorts of questions are people asking? What are they most concerned about?
Well, I haven't heard about what kinds of questions they've been getting on the hotline this year, but I've been in the hotline in years past, and a lot of the questions are, when is the vaccine going to be available? Where is it going to be available? Things like that. I'm assuming that they're asking a lot of questions about the disease itself, what are the symptoms and so forth. Okay. But I have not talked to anybody who's been on the hotline to. We also have another triage line for people who are actually ill and who want to know what to do.
All right. I want us to get to the vaccines and how that's being distributed, but we do have a phone call from Brian. Brian, go ahead and state your question, please.
Hi there. All over the summer, they were having buses come in by the library. It's from Mexico. And I'm just curious, nobody was there to check those people, being as this originated in Mexico. And it's that way across the country.
So there's some question, is there any screening available to, and we've touched on it a little bit, to determine if folks that are perhaps new to the community are contagious?
No, and not in the way that he's suggesting, and it would not be practical. Even at the beginning of the outbreak, it moved very rapidly. Like I'd stated before, you're infectious for a while, at least maybe a day before you even have symptoms. So screening for this of that nature would not be very practical. And there's really no way you can contain influenza once it starts. You can slow it down and you can ameliorate symptoms and do a lot of things, but it's contagious enough. You're not going to stop it at a border.
And we were talking earlier before the show began about tests that you can take in the clinic to find out if you've had it. Some people are wondering if they should take the immunization because they think they already had H1N1. But if you could repeat that information about, it only tells you if you had type A, but it doesn't really tell you if you had H1N1, and your recommendation for vaccination anyway.
Okay, well, yes, when people do go in and a physician does feel that they have H1N1 or influenza-like symptoms, sometimes they will test them, and what they use in most places is a quick test for influenza type A. And the test is a pretty good test, but a negative test of that sort does not mean you don't have it. Okay. Also, a positive test suggests that you have influenza type A, and because H1N1 is the dominant form of type A influenza at this point, they often will tell their patient that you have H1N1. But in terms of confirmed tests, the only tests that are being confirmed are those that are in patients that are hospitalized, and they are being sent up to the state health department for confirmation. So they're a rather small number that have actually been confirmed. So long answer to a short question is that if you've even been told that you've had H1N1 and under those circumstances you've not been hospitalized, you should still get the vaccine if you have that opportunity.
Okay, and no negative impact, you mentioned, to getting the vaccine even after you've had it. All right. We do have another phone call from Trina.
Hi, thank you for taking my call. I've been told that once you have the H1N1 that you can't be reinfected. So I was wondering how true is that?
Okay, thank you for your call. Is that true?
It's unlikely that they're going to be reinfected if it is in fact H1N1.
Okay.
But the critical thing is that there are a lot of respiratory viruses out there that can act in the same way, and people can have the same kinds of symptoms we presume that it's H1N1, but the tests aren't confirmed, so we don't know that for sure. And we have to go ahead and proceed as if they don't. When the vaccine's available, we need to give as many people as we can.
Even those that get hospitalized, less than half of the tests that come back positive. So it's important to get that vaccine if you can.
And if they're infected with H1N1 now, they can still get the seasonal influenza later on. So that's important that they get both vaccinated for that too.
Very good. That's a common question I've heard is, do I have to take both of them? How many doses of each one do I have to take? Who can give us the rundown of what vaccines and how many shots of each you get? And if you can also touch on the injection versus the mist. I'd like to tackle that one.
Well, there's 4 types of vaccine. There's the live attenuated influenza vaccine. That's the flu mist that they spray up the nostrils, and for the H1N1. And there are also inactivated vaccines. Those are the injected vaccines for the H1N1. And there are, I think, 3 different manufacturers for the inactivated and 1 manufacturer for the live attenuated, the flu mist type of virus. There's also 2 types of influenza immunizations for the seasonal flu. One of them is the flu mist, the live virus vaccine. The other one is the inactivated vaccine. So there's 4 different types of vaccine for the seasonal and for the H1N1.
Okay, Patty, how many shots of each do we need?
The children that are, for the H1N1, children that are 9 years and younger will need 2 doses, 30 days apart, of any of the vaccines, the seasonal or the H1N1, if it's the first time they're receiving it. Okay. The first year they need 2, after that 1.
Is that under evaluation? There was some discussion. The World Health Organization said, nope, you only need 1, and the U.S. kind of said, well, we'll think about that. Have they thought about that, or that decision hasn't been revisited just yet?
Early on, when it was being tested, we were testing people for how much immunity they actually acquired, and people that were 18 years and older developed immunity rather well, and so one dose was established quite early for the adults. It took a little while longer for us to decide at what cut point, but they've actually published levels of immunity that are acquired from at the different age groups, and the younger ones don't acquire immunity quite as fast.
Okay, so you're saying 2 doses,
2 doses
for 9
up to age 9.
Okay, and how young can you give a child a vaccine, either H1 or seasonal?
It depends on the type of vaccine.
Okay. Right.
The live attenuated flu mist, we only give that to children that are 2 years and older, up to age 49.
Mm-hmm.
Okay. If you're 50, you're not eligible
so
for
we
it.
Can't get it.
That's right.
Okay.
And you have to be well. We don't give it to people that have underlying conditions, and we don't give it to pregnant women because it is a live virus, even though it's very weakened, attenuated.
Okay. All right. And how are vaccines being distributed? With the emphasis on children, are they being distributed in schools, or what's the general? I realize probably everyone's doing it a little bit different, but give us a picture of how that's going out and how much is available.
Well, there's not as much available right now as we wished. Right now, because there isn't enough vaccine for everybody, we're limiting it to a small group of people. It'd be pregnant women, and here you might have to help me because I sometimes can't remember. Would be people who care for children under 6 months of age, because the 6 months and under can't get the vaccine. And then it's children from 6 months of age to 4 years, and then children 4 to 18 who have an underlying condition that makes them more at risk. And healthcare providers and EMS providers who have direct care with, or who provide direct care to somebody with influenza-like illness.
Okay.
So those are the only people who are getting it right now. As soon as the vaccine becomes more available, then the group of people that we'll give it to will expand a little bit, and hopefully within a relatively short period of time, we'll have enough vaccine for everybody who wants it.
Okay. I want to come back to doses and availability, but we do have an audience question. Would you please state your question?
Yes. In 1918, with the other influenza epidemic, several of the deaths were connected to respiratory problems such as pneumonia. And I'm wondering if the epidemic that we have now is also connected to respiratory problems.
Okay.
Well, yes, actually it is. That was one of the concerns we had, we've always had for pandemics, is that sometimes pandemics present themselves differently than the seasonal influenza, more severely. In the 1918 flu, for example, people could die within a couple of days, and with total body shutdowns. It was a different type of influenza than what we're seeing now. This one, fortunately, is more like a seasonal influenza. But in all influenza, as Patty mentioned before, pneumonia is one of the primary concerns, both pneumonia directly caused by the influenza and secondary pneumonias, bacterial or viral, that come along after you've had the influenza because you're in a weakened state.
Another thing, too, is that fortunately the resources we have to fight pneumonia are a lot better than they were in 1918. There were no antibiotics, and I don't know if they had ventilators and some of the other things we can use nowadays to keep people alive. So there's a difference there, too.
And the antivirals. Fortunately, they're working for this particular influenza. Sometimes they don't. Sometimes there's resistance.
Okay. Thank you for your question.
Yeah, thanks.
All right. Let's come back a little bit to the availability of vaccines. When we hear the word pandemic, that often causes a great deal of concern among the public and perhaps a little stampede to the nurse's office. You talked about, the calls that are coming in on the hotline and overwhelming the personnel. Some of the vaccines are given out, and they've done a good job of publicizing these age groups and these, categories of folks that are eligible. But some folks want their vaccine and they want it now. Give us a sense of volume and any prediction that you can share with us on when additional vaccines will become available and if you expect there to be long lines at these various clinics where they're distributing the vaccine.
I don't know the exact numbers of vaccine availability, but as I mentioned before, they're small enough right now so that they're given to a very restricted group of people. On our website, we indicate that it'll be sometime after Thanksgiving before the much larger supplies of vaccine are available. So it's going to be a little while. But as soon as we get enough vaccine for that first restricted group, then we'll start expanding to the next group out, and then hopefully at sometime in the relatively near future we'll be able to vaccinate anybody who wants it. Okay. Whether or not there's going to be big lines for it, I'm not sure.
That's been variable. Sometimes there's not a lot of people show up. Other times there's long lines.
It seems that there's more demand for vaccine when there's a shortage of it than when it's plentifully available.
And unfortunately, even in the narrow group of people Eric did a nice job of detailing there. There's not enough vaccine right now for those people. And also, because there's not enough going around, the state has had to use a random number system to deliver the vaccines. So different places are getting different amounts at different times. So you may be in the same city with 3 different hospitals, each of them having a different amount of vaccine, and maybe one has the inhaled type, the other only has injectable, and so forth. And you can only use some of these vaccines for different groups.
Yeah.
So it's made it very, very difficult for both the providers and the public in, who should get this vaccine? How come I didn't get it when they got it across the street, or, that sort of thing. So very understandably, frustration with both the people that have to give the vaccine as well as those that are waiting for their vaccine.
Sure. All right, we do have both an audience question and a question on the telephone. We have a call from Corey.
Again,
Corey,
if you need help, hang up and then dial your operator.
Go ahead and state your question. Okay, we'll have to come back to Corey. We have an audience question. Would you state your question, please?
Thank you again. Now, this might just be something come into my head, but as I was listening to the news reports on the outbreaks and different things going around the country, it seemed to me that Dallas, Texas was coming up an awful lot, and especially over the vaccine availability. Seems to be quite a bit more concern about it down there. And I was just wondering, it seems sometimes like the flu tends to hit down in the south quicker and longer and harder than it does up here. Is there any truth to that, or am I just making this up?
I know I haven't paid much attention to what's going on in other states because we've been so busy in our own backyard. Do you know anything about that, Larry?
Well, with this one initially, I think the South did get hit a little harder first. I think it varies though from season to season. Where it seems to show up first and how hard it gets hit. Even within the same state, you'll see variances from year to year. I don't know whether that's just luck or what the contributing factors are there. Probably exposures of maybe large groups or something of that nature that kind of ignites it in a given area.
All right. We have another phone call. We have a call from Olivia. Olivia, go ahead. You're on the air. State your question, please.
Can I get a shot if I'm pregnant?
I think she said, can I get a shot? Can she get a shot if she's pregnant?
Yes, we recommend that.
Yes,
she would
no matter what stage in the pregnancy?
The only thing that they can't receive is the live attenuated, the mist.
Okay, so no mist.
They do need to have the inactivated injection.
The injection. So yes, you can. Thank you so much for your call, Olivia. All right. When you talk about the availability of vaccines and as that expands, do you anticipate, I've heard from a number of seniors they really wish they had been eligible in this first round. Do you anticipate they will be a next group in the next expansion? Does that make sense?
What we've been told is that there's enough vaccine in the production lines that towards the end of this, when everybody else has been, then anybody probably who wants it will get it. That's what we've been told now. So, and we're hoping that there will be enough in that case. But as Patty mentioned before, there is some evidence of immunity, both in serologic studies they've done as well as just the epidemiology showing that there are very few people that are older that are getting it. So there seems to be some residual immunity, probably from a past exposure or perhaps vaccines of the past.
Typically, the seasonal flu occurs in the nursing homes. It's a real severe problem year after year in the nursing homes. And so far this year, we have not seen influenza in the nursing homes to any great degree.
And I think that's where a lot of the deaths occur from seasonal influenza or in nursing home residents.
And you'd recommend the senior population go ahead and get their vaccinations for seasonal flu and then just
Absolutely.
kind of get in line
year.
when H1N1 comes
year,
along.
you bet.
All right. We have another audience question. Go ahead, please.
A quick question. I was just wondering if, like hand sanitizer, how it kills germs and germs can build immunity, is it possible that we might have like a different form of H1N1 next year from all this hand sanitizer and how they can transform?
Good question.
Well, the hand sanitizers work by, most of them are alcohol, and they kill the virus. There's been no evidence that the virus becomes resistant to that. As far as changing next year, the virus changing next year, it could go through what we call a drift and become slightly different. That happens all the time with seasonal influenza, so that's a possibility. And I'm sure that they'll be monitoring the virus to see if it does drift a little bit.
It wouldn't probably be due to the sanitizer.
No, probably not.
Thank you for your question. So it's a little bit different than when we talk about antibiotic resistance. Hand sanitizer doesn't act in the same way. All right.
You might want to add to that in your hospital.
Yeah, one of the questions that I hear a lot, people say, well, all of the surfaces that we touch, the handrails and the keyboards and the phones and those kinds of things, should we be wiping them down more often than we do? And, certainly there's nothing wrong with a little bit of extra due diligence as far as cleaning your environment. But the most important thing is the hand hygiene. And, protecting yourself. You have to be the one that guards against an exposure. We don't live in a sterile environment. There are contact surfaces everywhere, and the hand hygiene, and then again, as someone else mentioned earlier, not not infecting yourself by rubbing your face, your eyes, your nose.
And how practical, when we talk about how we're going to prevent this from spreading throughout our community and how conscious we must be, because, as you said, Larry, we don't always know we have it because it shows up before those symptoms arrive. Our pastor in our church recommends hand bumping. We don't shake hands in church anymore. Is that effective, or what kind of recommendations would you give to the general public besides hand washing to mitigate the impact of H1N1?
Well, probably as important as anything is staying home if you're sick. And if you cough, just cough into your sleeve or into a tissue and throw it away. Things like that are extremely important. If a child is in a child care center or school, send them home if they have influenza-like illness. They shouldn't be there.
I think too, that what I'm hoping for being in public health is that some of these things we're teaching people about this particular disease they carry through, because it's going to prevent a lot of other diseases. If they wash their hands or cover their cough or stay home when they're sick, there are going to be a lot more well people out there for longer periods of time.
Yeah.
All right, we've got one more quick audience question. Go ahead, please.
If you tell someone to stay home when they're sick, is it inevitable that everyone who lives with that person in their household is going to get sick too, or how can they prevent themselves from getting their family ill as well?
I can maybe answer this one from the Red Cross's standpoint, is that we're recommending that you designate one person at your home to be the healthcare provider, and that one person would tend to the sick person. And depending on the severity of their illness, they may need to stay in one separate room, but that not everybody is in contact with that one person. As of right now, the flu isn't lasting very long, maybe a few days, in extreme cases, maybe 7 days, but I know it's not that long to kind of keep someone separate from everybody else,
the rest of the household.
And some other things. People are concerned, well, can their laundry be washed together? And we're saying, yes, you can wash everybody's laundry together, but that you're washing your hands after doing the laundry.
All right,
and just
great.
Basic things.
I'm going to have to, those are some great suggestions. I'm assuming we can go to Red Cross to get additional information. I want to thank everybody for being here today and sharing some information on this H1N1 influenza. And if folks have questions, please contact your local health provider. Remember, make sure to check out ksmq.org for more resources, including links to some of the sites we mentioned during tonight's program. Thanks to our in-studio audience and for everyone at home. For all of us at KSMQ, I'm Stephanie Passingham. Have a good night.